Today, we're ranking sleep aids from worst to best. All of them. Melatonin, Z-drugs like Ambien, Benadryl, alcohol, all of them. But in order to do that, we have to ask a better question. What kind of sleep problem do you actually have? And what is it going to cost your brain and body tomorrow morning? Because there are sleep aids that help you sleep. There are sleep aids that help you fall asleep but make the second half of the night worse. There are sleep aids that don't really fix sleep, they just sedate you. And then there are sleep aids that work so well that people forget about their downsides. So today we're ranking sleep aids, not in a dumb internet way. I'm a pharmacist and board-certified clinical nutritionist. So we're ranking them based on clinical data, and more importantly, what am I actually comfortable recommending to my family and friends versus what would make me nervous to use them every single night. Quick disclaimer, this is adult focused. This is not personal medical advice. If you're pregnant, elderly, dealing with sleep apnea, bipolar disorder, substance abuse history, complex psychiatric medication use, or you're giving something to a child, that's a different conversation. And that's part of the point. Sleep aids are not one category. They often get lumped together, but they do totally different things. Some work on the circadian rhythm, some reduce wake signaling, some increase sedation. So I'm going to rank them like we're in school, F to A+. And I'll tell you where I think supplement blends, including our essential sleep formula, actually fit. Let's start with the worst one, alcohol. Alcohol is probably the most common sleep aid people don't call a sleep aid. And I get why people use it. You're stressed, you have a couple drinks, you feel relaxed, you fall asleep faster. But alcohol is a dirty trick. It helps some people fall asleep, but then it punishes them later. You get worse sleep architecture, more fragmented sleep, more wake-ups, more bathroom trips, more snoring, more reflux, more heart rate elevation, and usually worse sleep in the second half of the night. That's why people say, I slept 8 hours, but I feel like trash. Because being unconscious isn't the same as being asleep. If someone hits you with a brick, you'll be unconscious, right? But you won't wake up well rested. So as a sleep aid, alcohol is more like the brick. So alcohol gets an F. Not because you should never drink, but if the goal is better sleep, alcohol is actually one of the worst tools. It helps you fall asleep, but it absolutely steals from tomorrow. Also in this dubious F tier, unless there's a real psychiatric indication, Seroquel type use just for insomnia. There are situations where anti-psychotics are appropriate. Absolutely. I'm not saying this is a bad drug, but using them casually for the lone indication of just because someone can't sleep, that's not a gentle sleep aid. That's a heavy medication with potential side effects, weight gain, movement issues, blood sugar issues, next day sedation, and a whole lot of baggage. I'm not saying no one should ever be on it. I'm just saying if the only target is sleep, you better have another reason. Verdict, it's an F, not a casual insomnia tool. Now let's talk about the big OTC category. Benadryl, Z-Quil, Unisom. Their generic names, diphenhydramine, doxylamine. These are everywhere, and that's the problem. People think if I can buy it next to toothpaste, it must be harmless. No. These are first-generation antihistamines. They make you sleepy because they're sedating. But again, sedation is not the same thing as high-quality sleep. There's also a big issue with the anticholinergic burden that these place on you. Dry mouth, constipation, urinary retention, brain fog, and most importantly, next day grogginess. For older adults, this category gets especially ugly. Serious fall risk and confusion. These are the classic works tonight but cost you tomorrow. Again, I'm not saying that someone taking Benadryl once after a bad travel day is doomed, but if someone tells me they take it every night, that's a red flag. So the verdict, fine is a rare emergency tool for some people, bad is a nightly sleep strategy, especially in the elderly. This category gets a D. So now the prescription drugs that everyone knows, Ambien, Lunesta, Sonata, these work, I'll be honest. If someone says, I took Ambien and I slept, I believe them. But this is where the ranking gets more complicated because effectiveness is not the only category. These drugs can come with next day impairment, dependence patterns, tolerance, rebound insomnia, and the rare but very real issue of complex sleep behaviors, sleepwalking, sleep driving, doing things while not fully awake. They're rare, yes, but serious enough that the FDA put major warnings around this whole class. So I don't put these in F tier because these can be useful. There are patients where short-term use makes sense. Acute insomnia, travel, crisis, carefully selected patients, monitored use. But as a casual, nightly, indefinite sleep solution, I don't love it. So the verdict is they're effective, but they're not casual use. They get a C for routine use, B if you're talking about a short-term scenario. Next, we have the benzodiazepines, temazepam, lorazepam, alprazolam, diazepam, better known as Xanax, Valium, etc. This whole family, okay? They can absolutely make people sleepier. But again, what are we buying? Sedation, even higher dependence risk, tolerance, memory effects, falls, respiratory risk in the wrong patient, danger when mixed with alcohol or opioids. So I'm not anti-benzodiazepine in every situation. There are cases where short-term use, even for sleep, is reasonable. But for chronic insomnia, this is not where I want most people living, especially if someone already has anxiety, alcohol use, sleep apnea, or a history of dependency. Also, coming off of these has very serious side effects and it's very difficult to do. So the verdict, powerful tool, bad default option. I'll give it a C if we're grading on a curve, D if being used very casually. Now we have to talk about Trazodone. Trazodone is probably the king of my doctor gave me something for sleep. Here's my honest take on it. Trazodone is not crazy. It's not evil. There are people who do very well with it, but it is way more popular than the evidence deserves. A lot of people think Trazodone is automatically safer because it's not Ambien and it's not a benzo like Xanax. That's too simplistic. It can cause morning grogginess, dizziness, orthostatic hypotension, which is a sudden drop in blood pressure, especially when you stand up, dry mouth, weird dreams, and in rare cases, priapism. You can Google that one. I'm not explaining it in this video. And clinically, I see a lot of people who don't know whether it's actually improving their sleep or just making them feel drugged. That's a very important distinction. If someone has depression, anxiety, and insomnia, maybe Trazodone makes sense in the overall bigger clinical picture. But if the only problem is sleep, I don't think Trazodone deserves the reputation that it has. Verdict, common, sometimes useful, generally overrated. Trazodone gets a C. Now melatonin. This one is misunderstood by almost everyone. Melatonin is not really a knockout pill. It's not the natural Ambien. Melatonin is more like a timing signal. It tells the body, darkness is here, night mode is coming. That makes it very useful for things like circadian rhythm problems, such as jet lag, or if you have documented delayed sleep phase. People who naturally drift later and later, also a decent option. Some work shift situations. But if the issue is, and this is for many of us, my mind is racing. I wake up at 3 a.m. I'm so stressed. Melatonin's not really the best tool. Also, I think the dose is often too high. A lot of people are taking 5, 10, even 20 milligrams as if more necessarily equals better. Those are supra or above physiological doses, and it can have a number of nasty side effects, vivid nightmares, headaches, and next day insomnia because your liver can't clear that much. So you're still signaling to your body that it's nighttime when it's actually 10 a.m. And that's without mentioning the awful quality control of the junk you find in stores. One study looked at 31 brands of melatonin and found anywhere from 83% less than labeled on the bottle to 478% more than what's labeled on the bottle. So it is critical that if you are going to try melatonin, you buy from a reputable brand like ours, like it is in our sleep essentials, and we'll get to that in a moment. Melatonin works best in small doses, the 3 milligram, to help reset your circadian rhythm. When you have to get up extra early, when you're traveling different time zones. So melatonin has its uses. It is not trash, but it's overused and misused. So melatonin gets a solid B for circadian problems. As a generic insomnia fix, I'll give it a C. Now let's talk about the supplement lane. This includes things either alone or in combination like GABA, L-theanine, glycine, taurine, magnesium in some formulations, sometimes herbs like lemon balm, passion flower, or other calming compounds. This category is not, knock me out, and it shouldn't be marketed that way. This category is more, can I help my nervous system downshift so that sleep is easier? That's a different promise. And honestly, that's where I do like supplements better. not because they're fake prescription drugs or versions of it. They're not natural sedatives, but as just a support for the transition into sleep. This is where our essential sleep formula fits. It has glycine, GABA, taurine, L-theanine, 5-HTP, and 3 milligrams of melatonin. So I would describe it to you this way. This is not designed to club you over the head. It's designed to support the sleep readiness pathway, calming neurotransmitter tone, relaxation, and the body's transition into sleep. That's the honest lane. But there's nuance. The melatonin makes it partly a circadian product. The L-theanine and the taurine make it more of a calming product. The GABA-glycine piece supports the relaxation angle. The 5-HTP means we need to be thoughtful when people are taking SSRIs and medications that work on serotonin, even certain migraine meds, things like that. So I like this option for most people, especially for occasional sleep trouble, difficulty winding down from stress, people who want support to sleep but still want to wake up functional. But again, this is not the severe insomnia that this fixes it. No, severe chronic insomnia needs a deeper look because there's sleep apnea, anxiety, depression, thyroid issues, pain, alcohol use, caffeine timing too late in the day, screen use, kids waking you up, schedule chaos, all those things matter. So the verdict, the supplements, B. B+ for the right person who just needs a gentle downshift, definitely something to be considered before pharmaceutical interventions. Now we get into the boring but useful prescription tier. So we're talking about low-dose Doxepin and Ramelteon. These are not the sexy sleep meds. It's not the Ambiens, etc. Nobody is bragging about these on TikTok, but they can make sense. Low-dose Doxepin is more of a sleep maintenance tool. So this really fits for that person who falls asleep pretty well, but wakes up at 2:30 or 3:30 in the morning and can't stay asleep. That's where they fit. And again, with Doxepin, I'm talking about low dose, 3 to 6 milligrams, not the old school higher antidepressant doses. Now, Ramelteon is different. It works more through the melatonin receptor pathway. It's not a controlled substance. It's not really a knockout medication, but for sleep onset problems, especially where timing and circadian rhythm is part of the issue, it can be reasonable. So the verdict, it's not flashy, but it's cleaner than many people realize, and the right patient, I'll give these a B+. Now, the newer, more interesting prescription category, the orexin receptor antagonists. These are things like Dayvigo and Belsomra. These are fascinating because they're not just smashing the brain with sedation like the Z drugs, like Ambien or the Benzodiazepines. They work more by reducing the wake signaling. That's a very different idea. Instead of just forcing sedation, they're targeting one of the systems that keeps you awake. That doesn't make them perfect. They still can cause next day sleepiness. They can be expensive because they're new brand drugs. They're prescription only. They're not for everybody. But mechanistically, I do like this category, especially for people with sleep maintenance issues, the people who can fall asleep but have trouble staying asleep. So this is not a lifestyle replacement. This is not a cure for bad habits. But as far as medications go, this is definitely one of the more interesting lanes. So the verdict, I'd give them an A for the right patient, not because they're harmless, but because the mechanism absolutely makes sense with very little downside. Well, now on to the annoying answer here. The only intervention that earns an A+ is not a pill. It's CBT-I, which is cognitive behavioral therapy for insomnia and the behavioral reset around sleep. The classic stuff you hear about: consistent wake time, morning light, stimulus control before you go to bed, not lying in bed awake for 2 hours, training your brain that bed equals stress, caffeine timing, not having it too late in the day, cool, dark room at night to go to sleep, treating sleep apnea, getting that checked, pain, anxiety, getting your phone out of the bedroom and never checking it in the middle of the night. I know nobody wants this one to win and we all want this magic pill answer, but because most chronic insomnia is not just a missing supplement or medication problem, it's a conditioned arousal problem. The brain starts associating bed with effort. I need to sleep. Why am I not asleep? I'm going to be wrecked tomorrow. I have such a big day tomorrow. Let me check the clock. Now I'm angry. Now I'm more awake. That cycle is brutal. No supplement or medication fully fixes that if you keep reinforcing it every night. So yes, we'll rank the pills, Yes, I'll rank the supplements. They can definitely be of help. The sleep aids have a place, but the foundation is still the foundation. Absolute A+ verdict for CBT-I. It's not sexy, but it's still true. So here's a quick recap of my rankings. F, alcohol for sleep. Anti-psychotics used casually just for insomnia. D category, the OTCs, Benadryl, Zequil, Doxepin as nightly sleep aids every single night. C, Trazodone, benzos, Z-drugs when they become routine or casual. B tier, melatonin when used correctly, calming supplement stacks, and sleep readiness formulas. B+, low-dose Doxepin and Ramelteon for the right type of insomnia. A, orexin blockers for the right patient, and A+, CBT-I, and actually fixing the sleep system. The big point is this: the best sleep aid depends on your sleep problem. If your clock is off, melatonin may help. Or check out our Essential Sleep. If your nervous system is wired, a calming stack may help. If you wake up all night, the answer may be totally different. If you snore, gasp, or wake up exhausted, you might not need a sleep aid. You might need a sleep study. And if you need something every single night just to function, it's not a moral failure, but it is a signal to stop asking what knocks me out and start asking, why is my body fighting sleep in the first place? That's where the real answer usually is. If you're looking for a natural supplement to help with circadian rhythm, our Essential Sleep is the best on the market. They're the right dose and a complete supplement stack to gently help your body reset. There's a link in the description, or go to our website, www.askjoedimatteo.com.
Dante, we are talking about an article that just came through JAMA, or a study, titled creatively, Muscular Strength and Mortality in Women Aged 63 to 99 Years. The big question they had is muscular strength associated with mortality in older women after controlling for aerobic activity, sedentary time, and fitness level? So is literal muscular strength something that contributes to, or hopefully helps prevent, death? Tell me about it. What do we got?
Yeah. So the researchers followed over 5,000 women, again, age 63 to 99. And this was a part of the Women's Health Initiative, specifically the OPACH study, it's called. And they did this for about 8 years. At the start, each woman, they did 2 simple strength tests. One was a hand grip squeeze. The other one was a time to stand up from a chair 5 times without using their arms. And they also wore activity monitors for 7 days. So they were able to get objective data on how much each woman was actually moving, sitting, not just self-reported information. Right. So over the course of the follow-up, a little over 1,900 women had died. The researchers essentially asked, do the strength tests predict who died? And if so, does that link hold up once you account for activity, sitting time, walking speed, inflammation, and kind of a whole long list of health factors? So the short answer to that question was yes, it did hold up. So the women in the strongest grip quartile had about a 33% lower death rate than the weakest. And so even after, all of those adjustments were made, they still, were able to see that signal. The faster chair to stand times, they tracked in the same direction. But the grip strength is what held up basically across every subgroup. And this included women who didn't actually meet aerobic activity guidelines, and also women who did use a walking aid. So the chair to stand, which was interesting, the chair to stand speed, it did weaken substantially once the health and clinical factors were accounted for. So this sort of suggests that specific test is more of a reflection of just general health status, as opposed to a proxy for something like muscular strength. Basically, what the authors kind of in summary garnered from this is that strength is pretty easy to measure in a clinic, and it's obviously worth maintaining as we age. It does carry a strong survival signal, as we mentioned, that aerobic activity simply doesn't, fully explain. So this is an association study. observational in nature, but it does definitely support what we see and what we recommend as far as, strength training guidelines go, and all that we typically recommend.
Let's talk for just a second. Let's break down some of these details. You said women in the top quartile. So for those not well versed in reading research, you're talking about, of all the women that were measured, about 5,000 people, the top 25% in terms of grip strength.
Mm-hmm.
That's what we're talking about.
Yes.
And
exactly.
they had what'd you say, a 33% lower risk of mortality than those in the bottom quartile?
Mm-hmm. Yeah.
Wow.
Yeah. So what that means, because that's an interesting way to, talk about survival over the course of a certain amount of time. So what that basically means is that if you picture two groups of women, same age, it's kind of the same health on paper, let's say, same amount of daily activity and walking around. One group had strong grips, the other had weak grips. Over the 8 years that they were followed, obviously deaths occur in both groups, but they happened approximately 30% less in the 30% less often in the stronger gripped group. So that's the gap. It's not that the strong people don't eventually pass away. Everybody does, obviously. It's just that the rate was lower across those years. And so it really does matter. The gap held up even after, the authors took out all the obvious explanations, age, how active they are, and other sort of things. So pretty strong,
that's incredible.
Pretty strong signal.
Before everybody goes out and buys one of those grip squeezy things from the 80s, grip strength is just a proxy for greater muscular strength, correct?
Exactly. So it's through the course of time, it has just been kind of like you said, the workhorse clinical proxy for total body strength. It's cheap. It's been validated across many different, metrics and tests and such. And then it does have some association and predictability in terms of hospitalizations, disability, all throughout the research.
I mean, I'm not saying I wouldn't love to see a study where they take women 63 to 99 and have them all do a 1 rep max deadlift, bench press, squat, just to kind of establish real baselines of muscular strength here. But it makes a lot of sense that you would go with grip strength.
Mm-hmm. Yeah, right. It's still, I think that at some point or another, we've talked a little bit about this, and there are obviously limitations with grip strength, right? So I think you're onto something there. I think we would rather see a baseline set of deadlifts, baseline set of something a little more taxing on the whole body. But again, it checks a lot of boxes. It does. It's not completely useless, as we see.
It's enough data that we can use it to go, it sure looks like the stronger you are, the less likely you are to die, just fundamentally.
Exactly.
That is fantastic. Well, if training your grip strength isn't actually what's going to help somebody live longer, what is the clear takeaway from this? What's the simple takeaway we can give people from this fantastic little study?
Yes. I mean, obviously this was kind of lighthearted, encouraging, but again, as always, we have to be careful how we generalize papers like this. It was, it looked at a very specific demographic, as we discussed. Women, certain age group, unfortunately, as tempting as it might be, we can't just fully generalize this to younger people, to all men, to this walk of life, this group. So you just, it's tempting, but that doesn't change what we ultimately want to leave you with. And that is, strength training is safe. It's already in the guidelines. This is just one more piece of evidence kind of pointing in that direction. So if you're a grandparent yourself, if you're around this age, if you have grandparents, that's the honest takeaway. Don't let your strength slip away over time. You want to track it if you can, not by, not with a dynamometer, but through actual gym related stuff or other whatever benchmark you're interested in. There's a lot of things to track, and clearly just another piece of evidence that shows that it does matter, kind of how strong you can stay over the lifetime.
Love it. Love it. Well, if that was helpful to you, please share it with somebody you know. That's how this show grows, is when you share clips or the full episode with friends and family, people that can benefit from this information. Come to our website, askjoedimatteo.com. That is where we have this show. We have the old show that started all this, the Ask the Pharmacist show with Joe DiMatteo Sr. We've got all the supplements that we sell there on our website, a blog that is updated weekly, lots of great stuff, askjoedimatteo.com. And if you've got any questions, email them to us, questions@askjoedimatteo.com. That's askjoedimatteo.com. We love your questions, and they make a great jumping off point for so many conversations like this. That's it for us. Thanks so much. We'll talk to you again soon.